Hi everyone, my name's Nat, and today we are doing our webinar on Friday rather than Thursday, but it will still be the same great content. We have previously discussed medication and prescribing from an ADHD lens, but now we're going to be opening it a bit more up for mental health. Why mental health? Why does that relate to neurodivergence? Well, a lot of people who are neurodivergent also have co-occurring mental health challenges. As well as, while we do not treat most neurodivergences with medication per se, we do support some of the characteristics. So for instance, I don't mind sharing, I'm on anti-depressants at the moment, but I use it for my OCD. And the thing is, the dosages are different. So there can be a stigma attached to it, even though it may not be for the purpose. Basically, the reason we call things like antipsychotics, antidepressants, is just because that was the first thing that they were created for. And sometimes they were created for, let's say, antipsychotics, quite a scary word, but actually people use them for many, many, many different things now. Oh, nice. Pippa says, hi Nat, hi everyone, I'm ND, nice. Or autistic and ADHD with occasional anxiety and depression. Well, great to have you. So as I said, normally we talk about neurodiversity, but you can't really talk about neurodiversity without talking about mental health. Hence why we're branching out a little bit more today. Here's our lovely team. We are all ND ourselves, so experts via experience, also trained professionals as well in our own sense in different sectors. Now, our last webinar, which was a really good one, I think, was education and neuroscience, learning about how we might use the knowledge of our brain to teach the people of tomorrow. And nice and interesting, we've actually got some more webinars coming up in the future around education and neuroscience because we had a really good response to this one. So Pharmacology 101 sounds like a bit of a big scary word. Just talk about medication and prescribing. We can't go into too much detail today because this is a big subject, and it's probably worth mentioning while I am doing my master's in neuroscience, this by no way makes me a qualified doctor. So use this as a starting point, but obviously go to your doctor if you want to make any life-altering decisions. So what are we going to hopefully look at? Well, we're going to be looking at why mental health and medication is ridiculously complicated, why a lot of the time we're treating what we don't know rather than what we do know. It's actually really difficult to treat mental health because it's not something we can kind of pinpoint. We're just not there yet. So a lot of the time it's process of elimination rather than kind of a real directed cause. We've got the effectiveness of pharmacology. So essentially, does the medication even work? Like I said, sometimes it's just throwing a really wide net and kind of seeing what you catch. And we've also got the future. So things are getting better, particularly if any of you struggle with mental health. It can be bloody depressing. And I tell you, the only thing that kind of gives me a bit of hope is knowing that things are improving all the time, which they definitely are. So we're going to be thinking about life and biology today. It's going to be kind of a philosophical session because these things, it's not just about the kind of hard, tangible outcomes, but also how as a society we think about medication. So understanding different myths and worries that come with having medication prescribed to you, as well as appreciating mind, body, and social connections. All that means is there's a lot of different factors that go into taking medication. For some people, they'll be dead against it. For other people, they might be too reliant on it. For some cultures, it might not be accessible. For other cultures, it might be taboo or frowned upon. So there's lots of different angles we're going to be looking at. Now, my first question to all you lovely people, how can we address mental health drug myths? So there are a lot of myths around the medication that we take. What can we do to squash them? And also, if any of you know any myths that you know to not be true, tell me about them. You know, there's always loads of ones like, if I take antidepressants and alcohol at the same time, I'm going to die. No, they just will not be that effective. Or you might have other ones where you're like, well, if you kind of ground up some tiger brain and rub into your skin, you're going to be amazing. You know, there's so many myths. Stop grounding up tigers. But there are so many things that we believe to be true that are not. Old wise tales, things your mum used to tell you. The internet is full of kind of miscommunications and false facts. And these things can be damaging. And there's some things which people just kind of completely not really like, oh, okay, it says take 3, whatever. Or maybe if it says take 1 medication every hour, how strict is it? So first of all, we've got conversations. Absolutely. We need to talk about it and talk about it with people who actually know what they're talking about. Do not just take your neighbor Karen's word for it. Speak to someone who knows. Medication are not temporary. Some have to take them for life. Absolutely. And the other thing, for instance, some medication, if you just stop taking it, you might as well have not taken it at all. Other times, medication, if not needed, could actually give you the condition that you were trying to treat. There are so many different kind of pockets to look into here. And also education. Yep, education. Medication is only one component. Lifestyle matters. Absolutely. Okay, thanks, April. Yep, it is just one part of the puzzle. So let's rank some mental health medicational challenges. So what I want you to do is rank which ones you think are the biggest challenges in order for us to combat some of the difficulties that we have around it at the moment. So let's see what we got. We've got, stigma is leading the way. Yep, essentially people's preconceived ideas and those ideas that they put upon other people. Access. A lot of us can't even get medication, ones that actually need it. I don't know where, most of you are assuming are from the UK, but in other countries like the US, medication can be really difficult to come by. There was some I had to pick up the other day and they're just like, yep, not in stock. The company that makes it has essentially gone bust. Or it was due to like the EU and us not being friends anymore and like not sending it. It was a nightmare. So we had to get a different alternative, but may have not been as good. Then we've got biological challenges. So not all of our bodies respond well to certain medications. They may just not be appropriate. We've got personal preferences. Some people like a more holistic approach, things that are a bit more natural. Other people may have their own like religious beliefs that might interfere or, just not gel well. And so you might have kind of views in a big wider scheme of things about what you think is the right choice. So essentially, there's a lot of things we need to overcome. Now we need to look at chemicals and mood. So when we think of like medications or drugs, we normally think of, like ibuprofen, paracetamol, things like that. But actually, we take drugs every single day, coffee, tea, like different types of food. All of it releases chemicals in the body, which then our body will interact with and will either make us happy, sad, energetic. They could do so many. Some big ones that you'll definitely have run into is ethanol, so alcohol. It is one of the most common drugs in the world, and it can alter how your body reacts. Now, interestingly, I would say if alcohol was invented today, it would be banned. But as a society, we have agreed it's okay. And that is a thing. A lot of the things that we deem good or bad aren't because they're necessarily good or bad, but it's what we have collectively agreed upon. So another example is LSD. Now, LSD is a big no-no in society. You shouldn't be doing it. But what's the difference between that and alcohol? Well, if you look at the statistics, more people hurt and kill themselves with alcohol than they do LSD. But then again, is that because less people take LSD or there's less documentation? There's also research that LSD can help people with mental health challenges, but there's not much evidence at all that alcohol helps people with mental health challenges. So as you can see, we've got lots of things that can do different chemicals. And then you've got things like having a tea or coffee in the morning where people like, there ain't no trouble. Oh yeah, and that's chocolate. Absolutely. Chocolate is a cheeky drug, but we don't have people kind of telling you how bad it is. Well, not that extreme anyway. So chemicals are natural and unnatural. Essentially, it's how our body works. Our body works with two main things, a bit of electricity and chemicals. Those two together is how our body communicates. And when we put artificial or official drugs in the body, we are just exacerbating or reducing the amount that these chemicals can interact and talk to each other. So here's a bit of a big screen, so take your time. The question is, how do substances like ethanol, remember that's alcohol, and LSD the drug reshape our views on mental health medication. So I'll read them out. Changing brain chemistry affects mood and mental states. Ethanol and LSD highlights benefits and risks of altering brain chemistry with medication. Therapy and lifestyle changes influences mental health. The role of individual choice in mental health treatment is raised. Ethanol and LSD can deepen our grasp on mental health treatments. So some 5 views here, and let's see. So all of you have selected absolutely agree with the first 3. So LSD and alcohol change brain chemistry and affects mood and mental state. Absolutely. We've got more evidence than we need for that. Ethanol and LSD highlights benefits of risk of altering brain chemistry. Absolutely. So every time you get in a fight, you end up crying on the floor, you start seeing like pink zebras floating in the sky. This is a direct consequence of taking these drugs, and there are definitely risks to taking them. So drugs are bad, but there can be benefits, and we'll explore that later. Therapy and lifestyle changes influence mental health. So absolutely true as well. This is why you don't have to solely rely on medication. Sometimes just going out for a jog can have the same, if not better, impact. Then the last 2, which some of you weren't so sure about, we've got the role of individual choice in mental health treatment is raised. So what we mean by this is, should it be a choice? If some people think that, say, drugs like LSD are helpful, should they be allowed to choose that route? Or should there be a list of designated things which are helpful? Some people say, yeah, alcohol makes me feel better. Is that a choice that an individual is allowed to make? And then we've got ethanol and LSD can deepen our grasp of mental health treatments. Absolutely. The more we study it, the better. And this is one of the big challenges at the moment, is that subculturally, we have a lot of drugs which have been deemed real bad, and as such are very difficult to research and to study. A great example is, let's say, magic mushrooms. They potentially have really big benefits to certain mental health conditions, but studying them is really challenging. Just to kind of clarify, I'm not saying any of these are good nor bad. I'm just saying there's potential, but it's difficult to research them.
I watched a documentary last year I think it was on BBC, it might be on iPlayer, and it was about them using LSD in treatment of depression. And it was a long-term study that they'd done with people, and they'd sort of taken LSD under controlled conditions in a hospital. And they reckoned low dosages over a period of time actually made really big differences to people. But obviously getting that funded and getting the further research into that, they reckon is going to be nigh on impossible to do.
Oh, no, thanks to and you're completely right. There has been some really promising research, and we really should continue that research. On the other hand, though, it can kind of make people think, well, I watched a documentary that said it's good now. I'm going to, take some myself. And there's so many things. One, the dosage, the purity, the controlled conditions. It's just kind of taking like a little kind of snippet isn't great. So there's so much more we need to understand. Oh, Pipera says, I use THC/CBD medically to manage my depression and to reduce the reactivity of my nervous system. I found it to be very effective in small dosage. And that's a really good one, Pippa. So for those of you who do not know, like CBD is like part of the chemicals that you'll get in cannabis, right? But it's a THC, which is the one where we're not sure about, because one of them can be psychoactive and the other one not. But one you're allowed, one not so much, depending where in the world you are. So not condoning or discondoning anything, but I just think we can't just look at the pure science. We also have how society views medication as well. And for those who struggle to understand how medication can be stigmatized, I think, ones that are considered illegal or on the border are very interesting case studies. So now we're going to look at something which is hopefully more of the future, is the socio-bio. And this is a more three-dimensional way of looking at mental health treatment and medication. Essentially, It intertwines the social approach, the psychological approach, and the biological approach when it comes to managing health and behavior. If we only look at one of these, we only get a one-dimensional view. If we take all of them into account, we can factor in, like I said, a more holistic three-dimensional view. So let's break socio-psycho-bio down. First of all, biology. This is our physical health, genetic vulnerability, and drug effects. So what does that mean? Well, physical health, how healthy are you? How often do you get sick? What's your general well-being? Genetic vulnerabilities. Do certain conditions run in your family? Because that will also have a big impact. Are we just looking at you as an everyday person or taking your whole history into consideration? Drug effects. Some people genuinely are less susceptible to certain drugs. It's why you might try something which would have worked for someone else, but when you try it, no effect. Then we've got the social sides. How do your peers view what you're doing? Your family circumstances, your kind of like religion, the money you are able to have, your relationships. These have to be things we factor. Otherwise, we're just limiting people from accessing certain help. Are there alternatives? And then we've got the psychological. So this is your more like mental health and seeing how these things affect you. So with that, we're now going to move a little bit on to stigma and medication. When we say stigma, again, though a lot of us know that we need these things, some people will not take the medication they need because they're worried about how the rest of the world will view them or look upon them. So we've got stigma and mental health and pill shaming. And pill shaming is a really big issue because I definitely know people in my life who will just not take medication because they have been kind of told it's bad or it's unhealthy. And I think it's about understanding rather than it being kind of black or white. So here is a nice quick question. How can we help those pill shamed for their mental health meds? What things do you think would have the biggest impact in allowing people to have the support that they and their doctor feel best for them without other people making judgments? Like we quite openly as a team, or as a very small group, said a lot of us are on medication, but not many people would do that. So what we've got at 40%, we've got educate others. Absolutely. We've got normalize medication use, advocate for access to care, and encourage communication. Well, immediately, all of these are going to be beneficial, right? So we've got supporting those pill shamed for their mental health meds, involved educating others, offering empathy, fostering environment, and understanding and acceptance. It's quite difficult because I'll just give you like one example. You know how I told you how I'm on these antidepressants? Well, my friend is also on the exact same antidepressants, but they take, I think, 50 milligrams, where I take 200 milligrams. And they said to me, they was like, dude, you're taking way too many. Like, that is not good for you. And keeps telling me that I need to ease off and get off of them. But what they don't understand is that 50 milligrams was actually perfectly good for depression. But for OCD, you need a higher dose. So this is the thing. If we start making these judgments, unless we know everything, we're potentially putting at risk. Because imagine if I decided like, oh, do you know what? My friend's right. I'm feeling a bit subconscious about what I'm doing now and drop down to 50. That massive drop could dramatically affect my mental well-being. So things aren't as always as simple and as black and white as they may seem. Now, what about too much medication? Because we have talked about when medication is good, but on the other hand, are we taking too much? Are we a pill-popping nation? There is a massive debate in the UK and worldwide around overprescribing. In the US, mainly because it's a for-profit organization, and in the UK, it's one of the easiest things to get across the line. If you need maybe a more like holistic approach, very difficult to get prescribed on the NHS. But if you want medication, easy. Get your prescription, pop to Boots, go home and take it. And then when you want a refill, just drop them an email. So GPs in England prescribed 70.9 million antidepressants in 2018, and it has only gone up since. That is an insane amount of medication that our country is relying upon. And we've got to ask ourselves, are we having too much of it? And if we are having too much of it, How do we reduce it without stigmatizing those who are currently on it and genuinely need it? You see how it's kind of like a fine balance act? Because, people tend to go to extremes. If you see this news like 70 million people on antidepressants, you'll say, oh, they definitely won't need it. Then when your friend says they're on antidepressants, you will probably say, do you really need it though? So let's explore that a bit more. So in the UK, out of every 4 people on antidepressants do not have depression. And again, at first sight, that sounds like we need to do something about this. There are so many people just taking the pills who do not need it. But remember how I said the names were created because that's what they were originally and first intended for. As we've learned and we've developed our knowledge, we have realized that drugs can have multiple impacts. So for antidepressants, it can help a number of factors, such as OCD. So would that count as depression? No. So it would add towards that stat, which can look a little bit scary. So here's some other stats. You can see how many people across the UK. Unfortunately, the more north we get, the more depressed we get. Yeah, so it's not great stat to be fair. You would think London would be more depressed, but oh well. So it is interesting, definitely. Now, while I said there are other conditions apart from depression, which would also have antidepressants, that's still not saying, though, that there are people who are on it who shouldn't be on it. But as I remember, if we go right back to the beginning, doctors really struggle in knowing what's wrong. What they are good at is working out what is not wrong. So it's process of elimination. So sometimes the drugs will not have much of an impact. If it works on you, amazing. If it doesn't, no harm. That isn't always the case though. But sometimes they'll try it. They'll see if there's difference. If it is, we'll continue, maybe up the dose. If it's not working, take you off of it. Now, a question to you. I've kind of answered it, but maybe you've got more to add. Why are many without depression on antidepressants? Are there any other factors? And again, this can be positive or negative. If we know 70 million people, an insane amount of people are on antidepressants, why? Why are so many people taking antidepressants these days? And I'm hopefully I want a wide variety of answers, okay? Because it really isn't as simple as one side. Okay, we've got bad training of doctors on mental health. I will say mental health is genuinely not most doctors' specialties. For me to find a good doctor, it was very, very difficult and time consuming, and it was hard. So yeah, that's definitely one answer. The wait for therapy puts pressure on GPs to prescribe. Yeah, I got that. And that is really true. If you have 10 minutes, right, when you go to the GP to tell them your woes and worries, and they have to give an answer. Giving medication, really quick, really simple. Anything else like therapy, the waiting list goes on forever. And then if something happens in the meantime, the pressure's on the GP. So you might use medication as like a bridge before you get to therapy. But sometimes that list can go on forever. When I applied for therapy like 4 years ago, they said, they'll put me on the waiting list. I'm still on the waiting list. And you think like, have they forgotten me? I think so. But every time I go to the doctors, they're like, oh yeah, have you heard from them yet? No. So, you have to take matters into your own hands, or you take whatever support is available. So I used to be not very pro-medication, but then I felt that I didn't really have a choice. So I had to go against my own personal beliefs because there wasn't really any other options. But the other side, and this is worth noting, is that while a lot of people who take antidepressants may not necessarily need them, 3 out of every 4 people with depression receive no help. And this stat is really important, right? So while a lot of people, 3 out of 4 who are on antidepressants do not need them, the same amount of people who have depression do not receive help. So we do not want to be too quick to pill shape and to tell doctors to ease up, because there are people who would genuinely benefit but just aren't receiving the support right now. So this argument is definitely two-sided. We're striving for the right interventions, and this again includes the social side, the psychological side, and the pharmacological side. We have to take the Holy Trinity in consideration if we want an outcome that benefits all of society rather than just the few who fit nice and neatly into each box. Remember, medication isn't super exact. It's not like it pinpoints the exact part. It will go around your whole body until it finds the area which it needs to support. And sometimes it will impact areas which didn't need support. And all medication has side effects. Sometimes they're not that bad, other times they are. So how can we guarantee proper help for those who are genuinely depressed? And this is a big question. If you have genuine depression, how do we make sure that those people are top of the queue, are recognized and get the help? Because at the moment, it seems like a lot of people who may not necessarily need it is getting the help, but people who do need the help, how do we even solve this disaster? Better education. I've never seen that in red before. Yeah, we definitely need better education amongst our professionals and our everyday people. We really just genuinely need it. We need essentially less stigma so people can go and get help. Because those who actually have depression are very aware of the stigma that is attached to it, so are less likely. Those who do not have depression may go for another reason. The doctors aren't really sure how to help them, so we'll just give them antidepressants. There are so many different reasons. Some are a bit depressing and sinister. Others are people with genuinely good intentions, but have restrictions or other things they need to take into consideration. So what we got? We got better education, we got communication, better training for professionals. Mental health is health. Yeah. More triage of mental health in first-line treatment and prioritize people who are unable to function. Yeah, maybe we do need like a prioritization list because it does seem the most vulnerable are less likely to gain the support. And again, while there are some cultures which it is more stigmatized than others, are we doing anything to reach out to those communities? So we're not just educating, but we're doing real hyper-focused education. Okay, so now let's look on the diagnostic challenges. We've talked about how broad mental health is. Well, if we want to create a more fairer approach, we are going to need some strict criteria so it's as simple as possible. Because it's weird that some parts of the country you can get support, other parts of the country you cannot. Maybe that's due to funding. But then also it can vary from practice to practice or doctor to doctor. So we've got the good old DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. This is like the Bible of mental health disorders. It also includes neurodivergent ones as well. Predominantly used in the US and around the world, but we also do use it in the UK. So let's take for an example, ADHD. We've got some challenges with this. So how can we make sure mental health diagnoses are accurate and useful? Because, we can give someone, say, an ADHD diagnosis. So what? Or someone might have attention deficit hyperactive disorder. Some people may not have the hyperactive tendencies. The label we give will impact the type of medication that someone may receive as well. So what we got here, we got update diagnostic criteria. We're on volume 5 at the moment. It was 2013. It's getting a bit old now. Do we need to make a more fluid document, which is ever evolving? Do we need to consider diverse perspectives? At the moment, we're very much we're not taking the whole triage, the whole kind of trinity into consideration in this diagnostic manual. We've got using standardized assessments. So we've got ones in the UK, ones in the US, depending where you go, there are different assessments. You might do one assessment and come out with ADHD. You might do another assessment and not have ADHD. So this is another big issue. You could potentially get penalized or different treatment depending on where you are in the world. OM says, is the DSM updated every 15 years? Do you know what? I don't know about that, if it's exactly 15 years or so. I'll have to look into that. I do know, though, it is a document that they are always updating, but in order to get it across the line, it takes a long time. There has to be a genuine reason. But what they do have is micro updates. So there'll be DSM 4.5. So there are micro updates along the line. Fatima says, masking makes it very difficult to get proper diagnosis and treatment. Yes, and a lot of these assessments do not take into consideration that people might be masking. They don't take into consideration gender or background, societal pressures, your countries, all of those things. And arguably, they definitely should. We've got integrate biological and environmental factors. So what do we mean by this? Well, if you're just looking at a manual, does it matter if you're living in a city or a rural town? Does it matter if you smoke or if you do not? There's these other factors which all have a knock-on effect, but we're not really ever focusing on them. Hence why, as you said, Fatima, masking and other factors can dramatically impact whether or not someone gets the diagnosis. Prioritize individual care, so more user focus. And the one that's got the most votes is continuous evaluate diagnostic systems. So always looking at them, always double checking. Should we use these manuals as the hard and fast rule, or more like guidelines or a starting argument? Now, when we talk about understanding mental health, as one of you very rightly mentioned, mental health is health. We can't really separate them. Often you got your physical health and your mental health, but really we should just be thinking health and well-being because they are all interconnected. A way of proving this is high blood pressure as an example. So high blood pressure is something which mentally it happens, but it happens physically as well. There are so many things like when you are anxious, that is a mental condition, well, a mental part, but you can also sweat, which is a physical thing. When you are depressed, you see how all these things, they work in. So physical stress can equal mental stress, which can equal societal stress, which can make physical stress worse. So it's all interconnected. But at the moment, we treat each one of these separately. So you'd have to go to a mental health nurse or doctor for mental health, a standard GP for physical, and for social, maybe you'd go elsewhere. So let's look at this lovely spinny wheel. Why are mental health issues diagnosed and treated differently than physical ones? We know that they should be treated together, but why aren't they being treated together? Well, hopefully this spinny wheel will tell us. Historical reasons. History has not been kind to mental health. You were a demon, a witch, insanity, you were not great. Broken leg will fix you up. Mental health disorders, let's burn you on a pike. Though that was a long, long time ago, these things are still kind of in our mind. These things are still shamed. We've done webinars before where we talked about how some cultures, those with autisms, are considered possessed. And, you don't want that. So you can see how it takes a long time for history to change. We've also got complexity. A broken bone, nice and simple. You do a scan, there's a break. Mental health, it's not something we can put a pin on. It's something which is different for everyone and something which we can't hold and tangible. It means it's just easier to keep it separate. It's more of the unknown. And what else? We also have understanding. So people have misconceived ideas, and insurance, which is actually a really big one. Insurance, when people pay out, like things to be really black and white. In order, do we pay for the help or not? With mental health, you can't do that, or at least not to the same extent. A good example is high cholesterol treatment. So if someone has high cholesterol, you can see it, and it's something that you can kind of treat, and we can go from there. Whereas mental health conditions, not as simple. So what physical health lessons could enhance mental health care? If we know that we can do certain things with physical health, could any of them translate to mental health? Oh yes, and Fatima says comorbidities are treated separately. So comorbidities is when you have one condition, you're likely to have another. And say if you have autism, maybe your anxiety will be treated separate. But the anxiety is a result of living with the autism in a society which doesn't understand you. So why are we treating them so differently if actually they are one of the same in many ways? So here we got what physical health lessons could enhance mental health care. Could it be prevention, early detection, holistic approaches, treatment options, or integrated care? And the answer is, we've got a joint tie, early detection and integrated care. So with physical health, we do tests to see how things are likely to happen. With mental health, we wait until the damage is done. And then we're like, with mental health, it's incredibly difficult to overcome. If we can detect it earlier on, wouldn't that be great? I would love to have known earlier on I was more at risk from stress and like obsession compulsions. So I could have worked about it rather than having to like try and fix myself afterwards. And integrative care, it's again, rather than me having to go to my GP every Monday and go to like a talking therapy every Tuesday, it was done as the same thing. So yeah, great answers. Now on to the last section, I believe, is the philosophical and mental health diagnosis. So what do we mean by philosophical? When we think about it, does it actually make sense? Why is diagnosis, philosophy, debated more in mental health than physical health? So what do we actually mean by that? Well, for instance, we have a lot of debate on what is mental health, where physical health, people have just accepted it. People are far more opinionated when you mention mental health than they are physical health. You say you got a broken leg, no one looks twice. You say you got schizophrenia, all right, now there's going to be a bit of discussion. So if we got mindset helps, yeah, people's mindset on what is considered normal or abnormal, acceptable, unacceptable is quite difficult. We also mentioned historical approach. We've got lack of physical evidence. Yep, a lot of people like pure hard physical evidence. We've seen how a lot of people might take certain medications who may not need them. And it begs the question, is it even real? There's a lot of conditions which people still haven't fully accepted, right? Well, ASD, autism spectrum disorder, has only been around since 2013, since it was reclassified in the DSM. What's to say it isn't going to change again? Well, that's not saying that the condition didn't exist before. It's just we have a better way of identifying it now. But we are still in the relatively early stages of our understanding on mental well-being compared to physical health, where we've come a long, long way. Science is not sure 100%. Absolutely. Science isn't a religion. Science is the understanding that we have a lot more to learn. Anecdotal evidence, yep, there's a lot of pseudoscience and a lot of things which aren't completely sure yet. We're still learning, lack of understanding. Okay, yeah, absolutely. The brain is a beautiful thing, but we know very, very little about it. And as such, there's more room for debate. If you can't see something, you can interpret it in many different ways. Or big pharma. Yeah, big companies, they make a lot more money from diagnosing everyone or prescribing medications to everyone. For instance, if you've got a broken leg, it's very clearly you need like a plaster or a kind of cast. If you don't have a broken leg, you definitely don't need a cast. Nice and simple. If your mood's a bit over the place, you're not really sure why someone might be, are they depressed? Is it anxiety? Is there something going on in home life? Doesn't matter. Give them antidepressants. So there's way more money in mental health. Capitalism. So when it comes to diagnosing the individual, our culture there are many other cultures that do it far different from ours. So for instance, in maybe rural ones in like parts of Africa and sometimes in South America, they focus more on the individual rather than the environment, comparisons to other branches of healthcare. So for instance, people will talk in the community. We've got a problem like Dave is struggling at the moment. What can we do? They'll then look at reports and they'll see how the general community is doing. They'll do surveys and then the community will diagnose. I'm not saying that's the best approach, but what it is saying is there are other approaches to how we currently do it. So we involve wider data and community members and community leaders. I don't know if you think that'd be good or bad, but I think it is interesting how it is done in other places. Now, if we were to do a similar approach, how might we factor in environment and social context in mental health treatment? Because again, at the moment, we focus very much on, okay, you're struggling, what do we do? But we don't look at so much like, for instance, if all of Wandsworth in London was having a massive increase in depression, should we do something about it? At the moment, we just look at the individual, when actually maybe there's wider factors influencing. So could we involve family members, caregivers, and community support, like the image? Could we tailor treatment to cultural factors? If we know that an area has a high population of Bangladeshi residents, should we understand their cultural aspects and what might be different factors for them? Addressing poverty and discrimination as social determinants. So when we looked at that map, why is it that the North is more depressed than the South? Well, they do have less revenue and money kind of being pushed up there. So if there's less job opportunities, less support, less care systems, you can imagine that more people would be struggling. But again, we're currently really using this information and data. Yeah, it is grim up north, I'm afraid. It's a lot rainier as well, but you do meet the funniest and happiest of people in terms of their wit and humor. So medication in mental health. Medication is part of the bigger picture. Antidepressants and antipsychotics are an example. They aren't the beginning or an end all. They are part of the solution for some. There's this really good quote from Marcus. He's a bit old now, but he says, medicines can only cure curable diseases and then not always. So what he's saying is they are far, far from perfect. So we shouldn't use them as the start and end. When we're looking beyond diagnosis, we would want to be treating symptoms with more. What is this even saying? It's meaning that rather than supporting a diagnosis, which, we don't fit nicely into little boxes. We're all individuals. We're treating individual symptoms, and you kind of build up a picture based on an individual's character. And we also treat it not just via medication, but also from a community or in a social perspective or a psychological one. Again, using those 3 different boxes that we looked at. Okay, almost there. What are the pros and cons of treating symptoms over diagnoses in mental health? Feel free to give cons as well if you have any. So rather than saying, all right, we're treating depression today, we'd be treating, say, you have anxiety when you're going to school. We're treating that exact particular example rather than just the blanket term for depression. Okay, what are the pros and cons? We miss the bigger picture. So we're only supporting the diagnosis. We're not looking at the detail. Very true. Short-term solutions, absolutely. You can make someone feel better in the short term, but are you let's say someone's getting bullied at school. You could give them antidepressants that will make them feel less sad. But if that bullying is continuing, the drugs aren't going to be helping. We've got tailored approaches, appreciate that we're all different, faster results as well. Yes, absolutely. Because again, if we are throwing a big net in and seeing what works, that is going to take a lot longer or process of elimination. If we're able to be highly tailored, much faster results, better outcomes, and probably a lot cheaper in the long run. So potential benefits, if we were to support people from a symptom base rather than a diagnostic base, is it's going to be person-centered, as in it is for you and you only. It'd be more flexible, giving you more options, allowing you to have a say in what works for you. Less stigma, because there'd be less to compare you to. And more holistic, which is, it would be kind of less drug-based. Drugs might be part of the solution, but it wouldn't have to be everything. Now, on the flip side, we also have some drawbacks, because it's not all rainbows. We've got a lack of clarity. It's really difficult to educate people when there's unlimited number of potential options that you could do. You could also risk abuse of power. Insurance covers, I know, while we were thinking of the insurance companies, they do care about this stuff. So how do we support them when things are so individual? How do you make these, who's high risk and who's not high risk? Research as well, stigma, it could bring a new set of stigma. While it might reduce some stigma, new stigmas will arise, and misinterpretations as well. Human beings tend not to deal well with ambiguity, even though it's what we seem to want. We struggle with it. If you do enjoy this, we are kind of diving in even deeper next week. And this is this session plus more. So when we're looking at pharmacotherapies, we're going to be looking at kinetic and dynamic medication. So essentially, the way drugs work, there's 2 different ways that they work in our body. And knowing how these different ways drugs work can give you a better understanding on what you're putting in your body. So, for instance, when you take alcohol, what is actually happening? And when you're taking antidepressants, are they different? You've got stimulants, you've got depressants, you've got uppers and downers, and it'll be a really useful session. The names look a bit scary, but honestly, it's not that scary at all. And it genuinely gives you a better understanding of what you're putting in your body. Oh, Philippa says it's helped me to know the difference between being a difficult person and being in a difficult situation. Oh, yes, that's a perfect way of describing it. Absolutely. I think when you take the whole perspective, you realize the situation is challenging and not you. So thank you for sharing that. We also have webinars that we've recorded, which, as well as this one, will be online shortly. And feel free to subscribe, watch previous ones, catch up. If you want to get in contact, here's our lovely contact details. Just drop me a message at nat@exceptionalindividuals.com. And that is everything. And we'll conclude today. Okay, not a doctor, but this is more food for thought to getting you to reevaluate how you look at mental health and how you might see potential support strategies and solutions. Oh, thank you, everyone. I really appreciate the lovely comments. It's been great having you, and apologies for changing the date, but I'm glad that those of you who can make it did make it, and see you next week. Bye, everyone.